Welcome to my channel Medicine Handy Points. Today we'll be discussing antiphospholipid syndrome and anticoagulation if needed during different scenarios of antiphospholipid syndrome. There are three antibodies in antiphospholipid syndrome. Number one is the lupus anticoagulant, which all of you may know. Number two is anticardiolipin antibodies. And number three is anti-beta GP antibody. Now, high risk profile patient, they are classified mainly on the presence or absence of antibodies. Okay, so the presence of antiphospholipid antibodies on two or more occasions at least 12 weeks apart means that the patient is having persistent disease activity. They are called high profile patient. If the patient are having 2 times the normal value of antiphospholipid antibodies, any combination of the three we discussed earlier, they are high risk profile patient. Or if all the three are positive, this means that a patient is a high risk profile patient. So we continue. Very high titers of antiphospholipid antibodies also suggest that they are high risk profile patient. Non-pregnant patient with a history of obstetric antiphospholipid syndrome means complication of pregnancy due to antiphospholipid syndrome are also high risk profile patient. Now, what is obstructed APLS? Obstetric APLS is if there are 3 or more abortions less than 10 weeks or there is a fetal loss more than 10 weeks of pregnancy. That is called obstructive APLS. So now the thing is that all these high profile patients should be getting prophylactic aspirin 75 to 100 milligram daily. APLS patient if develop venous thrombosis for the first time, now what should be our target, how we will approach it? We definitely have to start with warfarin with a target INR of 2 to 3, and patient should be getting it lifelong for unprovoked. Now, what if the patient develop a recurrent venous thrombosis despite being on warfarin? So we have few options. Increase the target INR to 3 to 4, or add aspirin to the INR as well, or give heparin because the INR warfarin is not working. What if APLS patient develop arterial thrombus for the first time, like stroke? Start aspirin and warfarin both with a target INR of 2 to 3. Now, what if APLS patient present to us with a pregnancy? So how we will approach this patient? If the patient has obstructive APLS history, means in a previous pregnancy she had a problems, or if she has a thrombotic APLS, give aspirin plus prophylactic heparin, and the patient should be getting it throughout the pregnancy. If the patient is just high risk profile patient, APLS with no obstructed or thrombotic APLS history, then that patient will be just getting aspirin only. Now, these patients should be getting APLS patient should be getting postpartum heparin 6 week for 6 week. If still pregnancy loss occurred despite the patient getting aspirin and heparin, then we have to consider therapeutic heparin rather than prophylactic. We can use HCQ or steroids can be used in the first trimester as well. If the patient is having thrombotic APLS and gets pregnant, ideally this patient should be given therapeutic heparin rather than prophylactic heparin along with aspirin. Thank you so much for watching. Appreciate.